Hello, welcome to the Radiology Economics and Policy Learning Electronic Toolkit, REPLETE. I'm Rich Duzak from Emory University, and this session is the first of two advanced vascular and interventional radiology REPLETE add-on modules entitled Vascular and Interventional Radiology Coding. This module is specifically targeted to address components of Level 4 of the Vascular and Interventional Radiology Milestones Project of the Accreditation Council for Graduate Medical Education and the American Board of Radiology. All of the other level requirements for vascular and interventional radiology are addressed in various modules in Levels 1 through 5 for diagnostic radiology. And so if you first complete those courses and then complete this module and the subsequent one on vascular and interventional radiology documentation, you will have fulfilled all ACGME and ABR economics milestones requirements for VIR. I encourage you to look closely at the spreadsheet accompanying this module on the RSNA's website to learn more about how modules map to different levels in different programs. The learning objectives for this module are as follows: to describe the unique circumstances surrounding CPT coding and subsequent billing for interventional radiology services that differentiate it from diagnostic radiology, to outline the history of and rationale for component coding and the ongoing evolution to bundled procedure codes in interventional radiology, and to identify opportunities for interventional radiologists to more accurately and compliantly code and then bill for their services. Here are some additional resources listed alphabetically by author for those who would like to learn more about the topics in this module. In the short time we have together in this session, I won't be able to tell you everything you need to know about interventional radiology coding, but hopefully I will be able to highlight for you some key principles to allow you to continue learning on your own. And as you do that, you'll need to make sure that you rely on authoritative resources. We have talked about the CPT codebook many times in various modules in the 5 basic levels of REPLETE, and I will continue to encourage you to avail yourself of that important resource. But as you'll soon learn, coding for interventional radiology is complicated, and so you'll need additional resources to help you guide your way through this specific coding topic. Fortunately, that's something that the Society of Interventional Radiology has been offering for decades as a membership benefit, each year publishing its Interventional Radiology Coding User's Guide or Coding Update. You see the cover of the 2018 book listed here. If you're an SIR member, this is one of the many benefits of membership that you'll enjoy. And if you're not already a member, I would strongly encourage you to join. Currently, dues for members in training are just $50 a year. A lot of what I'll be telling you in this module is information that you'll find in that book, along with a whole host of other complementary material. I introduced you in several prior modules to this diagram of the radiology service payment chain. Remember that that chain, like any other, is only as strong as its weakest link. And we talked about correct coding as one of those very vulnerable links, specifically spending an entire module talking about CPT coding more broadly in radiology. In this module, we'll take that a step even further and delve more deeply into coding issues that specifically impact interventional radiology. First, though, let's spend a few minutes refreshing your memory about some important issues related to CPT coding. You'll remember this graphic from way back in Level 1 of the paper version of the CMS 1500 form. Although our practices now nearly always submit our claims electronically, the fields you see here are all required elements for submitting any claim to Medicare or any other payer, whether you do it using paper or the internet. Perhaps the two most important of these codes you see listed at the top. ICD codes indicate why you did a procedure. In this regard, interventional radiology is pretty much like every other medical service. And CPT codes, the second listed here, indicate what procedure you did. Interventional radiology, again, is similar here. You will need to report your services using CPT codes. It's just that the coding is often more complicated. Why is this all important? Remember, without the correct ICD and CPT codes, payers won't be able to confirm medical necessity, and you probably won't get paid for your services. You may recall that CPT stands for Current Procedural Terminology. Under the Health Insurance Portability and Accountability Act of 1996, that's HIPAA, it was formally adopted as part of the nation's preferred procedural coding system. As such, almost all payers follow CPT rules to one degree or another. So, most of what I'll be telling you in this module will apply not only to Medicare, but much more broadly to private payers as well. And the CPT book outlines the rules under which its codes are to be used. One of those in the introductory instructions that's most relevant to interventional radiology is the accuracy imperative. Your coders are instructed to select the name of the procedure or service that accurately identifies the service performed. And they're additionally instructed to not select a CPT code that merely approximates the service provided. Specifically, they're told if no such procedure or service exists, then they should report the service using the appropriate unlisted procedure or service code. This is really important in interventional radiology because we have a tendency to use a lot of jargon. So if your coders don't understand what you did, they may assume that there's not a specific and accurate CPT code that applies and use an unlisted procedure code. That means that instead of submitting an electronic claim, which gets you paid quickly, they'll probably submit a paper claim with an accompanying documentation, which usually is a slow way of not getting paid. And so you'll want to make sure, through the use of standardized templates and ongoing communication with your coders, that they're aware of what services you are offering in your practice and that they know confidently how to code those services. You may recall as well that CPT codes used to report radiology services fall into two categories, Category 1 and Category 3. As an aside, Category 2 codes are quality measure codes that are largely being phased out in lieu of other methods for quality reporting. We won't talk about them anymore. Because the specialty is such a dynamic one, Category 3 codes are not uncommon in interventional radiology. That's because these codes are used to describe new and emerging technologies, the things that have historically defined interventional radiology. There's a low evidentiary bar for code approval at CPT. That means you don't need a whole lot of peer-reviewed literature to get one. And there's a low utilization bar for code approval as well, meaning that the service does not need to be broadly utilized to get a Category 3 code. That's all the good news. The bad news is that because these bars are so low, these are often deemed investigational services. So they're frequently not covered by insurers. How can you recognize Category 3 codes? You can do so by their alphanumeric format. Typically, they are a series of 4 numbers followed by a T, the letter T, which some people have said stands for tracking. So these codes track a service, but often won't get you paid for that service. In contrast, Category 1 CPT codes are what some folks colloquially refer to as real CPT codes. The bar to get these approved is much, much higher. They describe services that the CPT editorial panel has deemed established technology, meaning that there's ample peer-reviewed evidence to support their use, and that they're used by a large number of providers all across the country in a frequency concordant with the incidence of relevant diseases or conditions. Because of that high evidentiary, utilization, and overall acceptance bar, most insurers will cover these services. That means that you're typically going to get paid for services that you report using Category 1 codes. You'll be able to identify these codes by their fully numeric nature. That is, they are typically series of 5 numbers. Those numbers correspond to the families of services you see listed here. It's important to note that CPT specifically says the codes aren't restricted to use by any individual specialty, meaning that the codes describe the types of services, not the physicians who provide them. And that's important for interventional radiology, as we'll talk about shortly, because we use a lot of surgical codes in our subspecialty. Now, you may be saying, hey, I've already listened to a number of modules about CPT coding. Why are you putting me through this again? That's because interventional radiology coding is special. It follows many of the rules of coding for everything else, but for historical reasons, it's a lot more complicated. And so I'll try to put this all in context that hopefully will set you up for success as you attend workshops at the SIR meeting and read the IR Coding User's Guide in your pursuit of more information and knowledge. Back to the code family table. Part of the reason that interventional radiology coding is so complicated is because interventional radiologists do it all. Unlike diagnostic radiologists who report almost all of their services in the radiology family of codes, as an interventional radiologist, you'll have to familiarize yourself with a number of different code families. Since you're an interventional radiologist and not a surgeon, you'll be using and interpreting a lot of imaging, both for diagnostic purposes and guidance and supervision purposes as well. And those component services are all billed using Radiology Series 70,000 codes. But you'll also be doing a lot of invasive procedures. And almost all invasive procedures are reporting using surgical codes in the 10,000 to 60,000 series of the book. Remember again, you don't need to be a surgeon to use these surgical codes. CPT defines surgery codes as those describing nearly every invasive procedure. So it's not a restriction on the specialty of individuals who can use these codes. It's just the way that invasive procedures, whether minor or major, are classified. And you'll also be using a lot of medicine series codes as well. For some quirky historical reasons, non-invasive vascular imaging, and particularly arterial and venous duplex ultrasound, which is interpreted by a lot of vascular and interventional radiologists, is reported using 90,000 series vascular medicine codes. You'll also be commonly providing moderate sedation services in your interventional radiology practices. And moderate sedation falls into that 90,000 medicine series family as well. So you've got a bit more to learn about coding rules than if you were just doing diagnostic radiology. The other important issue with interventional radiology is that it's not typically a one-size-fits-all coding scenario, as you're familiar with for radiography, ultrasound, CT, or MRI. In most situations there, you'll use one code to describe the entirety of everything you did. And that's pretty much how things work in traditional surgery as well. There's a different code, for example, for a hysterectomy or a hysterectomy with an oophorectomy. But our gynecological colleagues typically report just one CPT code to report the entirety of their surgical procedures. Interventional radiology coding remains in flux, but a good bit of interventional radiology is still reported using what are referred to as component codes. It's sort of like an erector set, the kind that I used to play with as a kid. You have a big box of parts, in this case codes, and you put them together in unique combinations and permutations to describe whatever you built, whether it was a truck or a plane. Think of component codes as parts in that erector set. HCFA, the Healthcare Financing Agency, which is the old name of CMS way back when, blessed CPT, creating this approach to coding for interventional radiology back in 1992. It was in response to the very unique nature of interventional radiology at the time. And so to understand why we still have component coding, you'll need to understand that history a bit. So why component coding? I'm a lot older than most of the learners in Replete, so I remember back in the late 1980s and early 1990s when there was really no widespread knowledge of this thing called interventional radiology. There were radiology proceduralists and a lot of radiologists who helped with procedures, and they all practiced in very different ways. For example, I perform a lot of biopsies in my practice, and for almost all of them, I'm the only physician involved. But back when I was a resident, back in the day, that wasn't always the case. Our medical renal biopsies, for example, were typically done by nephrologists, but radiologists guided them using ultrasound. That was, whether right or wrong, the standard of care in many communities. And so CPT, remember again, it stands for current procedural terminology, needed to be robust enough to address all scenarios in play at the time. What that means was that separate codes were created for the procedure itself, that is the biopsy, and another one for the imaging guidance and supervision. When these services were performed by two providers, say a nephrologist and a radiologist, the nephrologist billed the surgical procedure code and the radiologist billed the imaging code. But when performed by just one provider, that physician, and now we're typically talking a radiologist, billed both codes to indicate that he or she performed the entire service encounter. I'm even aware of some practices way back when IVC filters were still placed via a cut-down, where vascular surgeons placed the filters, but radiologists told them where their catheters were and where they needed to go by supervising the fluoroscopy. Clearly, times have changed. The other piece of historical perspective is how interventional radiology has changed so rapidly. Decades ago, so many procedures were in flux. and done differently by so many different providers. So there was no one typical way to do a lot of services. And there were some services way back before CTA and MRA, like cerebral angiograms, which were done frequently but could be done in a lot of different ways. When you did one, for example, what did you study? Just the carotids, just the neck, or the head and the neck? Did you also study the posterior circulation? And if you did, was it done via one or two vertebral arteries? And so there were a number of catheterization codes. Those were the invasive so-called surgical codes, and a number of diagnostic codes, the so-called radiological supervision and interpretation codes, that could be used in a mixed and matched manner. The erector set analogy again, to describe pretty much any combination or permutation. We don't use those codes so much today. But we still have lots of ways of doing, for example, visceral angiograms, which are done pretty frequently, depending, say, on where a patient is bleeding. Did you need to study the SMA, an IMA, or perhaps just one vessel? And where and how did you embolize something? So component coding still has an important role today. As an example of component coding, you see listed on the left how an IVC filter placement procedure was performed up through the year 2010. There was a code for the IVC catheterization, 36010, and the IVC venogram, 75825, that was necessary to assess caval patency and anatomy. And then a code for the filter placement itself, 37620, which historically was used by surgeons, and the radiological supervision and interpretation code, 75940, which was used for their radiologist colleagues, providing guidance. As IVC filters became percutaneous procedures and could be performed entirely by one operator, now most commonly interventional radiologists, that provider was then able to report all four codes for an average Medicare professional reimbursement of a bit over $500. The fact that I'm an old guy with gray hair giving you a history lesson indicates that things are changing. Component coding is now getting phased out, and bundled codes are increasingly replacing those old codes. Why? You may recall from a valuation module long ago that the Relativity Assessment Workgroup, the RAW, of the CPT editorial panel and the RBRVS Update Committee, the RUC, looks regularly at codes that are frequently used together. And when codes show up on their electronic screens, showing that they're used together over 90% of the time, and now more recently 75% of the time, they often get reviewed, with the thought that component codes are no longer necessary. And so interventional radiology coding remains in flux, with many services still component coded, but also some now coded in the same traditional way as regular surgical procedures, meaning with a single bundled code, and some others, like dialysis interventions, with a bit of each, where some parts like interventions are bundled, but the diagnostic portions are still component coding. As I told you at the beginning of this lesson, it's complicated, and why in Replete we have specific advanced coding and documentation modules just for interventional radiologists. What does that evolution all mean? Well, IVC filters are a great example. What used to be done in a number of different ways by different numbers of physicians involved in various cases is now done in a pretty uniform manner by a single physician. And so the Relativity Assessment Workgroup, the RAW, saw these four codes getting used together quite a bit. As a result, CPT created one single code to describe the entirety of the procedure: the catheterization, the venogram, the road mapping, and the filter placement. That's CPT code 37191. Now, any new CPT code, as you know from prior modules, gets valued through the RVS update process, which is far more hostile today than it was in the past. And as a result, what used to get paid $528 now gets paid about $250, translating to a 53% reduction in physician revenue. And those cuts to interventional radiology, like diagnostic radiology of late, mean that radiologists really need to watch their revenue cycle operations more carefully than ever so that they don't leave increasingly scarce legitimate revenue on the table. I've told you about why interventional radiology is so complicated and why knowing a bit more about it is so important. But what do you need to know moving forward? I can't tell you everything in a single online module. There are weekend crash courses you might want to explore if you really want to get indoctrinated, but I can share with you a couple important principles as you see them listed here. First, don't do this alone. Interventional radiology coding is a team sport, and some interventional radiologists think that they can do a better job coding than they really do. Here's the abstract from an article that my team published way back in 2004. We looked at 549 interventional radiology encounters where interventional radiologists did their own CPT coding. Some thought that if they went to a workshop or two that they could do this all themselves. There were 62 physicians in that sample from 23 hospitals, and using their own procedure reports, we compared their coding with that was done by nationally recognized experts, people who had been invited by the Radiology Coding Certification Board to serve as content experts during test development. And when we compared coding by interventional radiologists to coding by that expert panel, interventional radiologists didn't do so well. They only coded 44% of their own cases correctly, and they had a bit of a tendency to overcode with regard to RVUs, something that could result in overbilling and thus create compliance problems for their practices. And not surprisingly, the accuracy of their coding varied by types of service. For some things like percutaneous biopsies, they did much better and got their coding right 74% of the time. But that still means they were wrong 1 in 4 cases. At the other extreme for vascular interventions, you just saw how complicated coding a simple IVC filter used to be. They were only right in 1 in 4 cases. The message here is a pretty clear one to me. Don't do your own coding. I think this is an area where interventional radiologists need to seek expert help. And fortunately, there are coders now certified by the Radiology Coding Certification Board, specifically in interventional radiology. You wouldn't let a general practitioner do a percutaneous ablation or TIPS in your practice, would you? So why would you let a general, non-specialty coder code for those types of services? The other message, again, since this is a team sport, is to take advantage of opportunities to educate yourself. In particular, take advantage of the great work done by the staff and the volunteers who put together the Society of Interventional Radiology Coding Guide each year. You don't need to memorize it, but you should be familiar with it and use it as a resource when you engage in discussions with your coders about how to document and how to code. The second thing you need to know is some basics of interventional radiology coding. Now, I just told you that you shouldn't be doing your own final coding, and I stand by that opinion. But that said, the more you know about coding, and specifically the requirements to report each code, the better a job that you will do in documenting your cases, so that your coders can then optimize all legitimate revenue due to you. And so that your claims can also withstand an audit if a payer wants to take a deeper dive. Let's then go through a few simple cases where I can show you how to leverage your SIR resources. Let's start with a real easy one, because you've already seen this one, an IVC filter. You see the code here, 37191, and from the CPT book, the narrative descriptor for the service. Note specifically that it's a bundle code. So what does it include? It includes the vessel selection, radiological supervision and interpretation, any road mapping, any imaging guidance, all when performed. It's a bundled code. Now, how would you code this case? I guess you could page through the entire CPT book and hope that you stumble upon the right code. Or you could use the charge sheets created by the Society of Interventional Radiology. If you look here, and I know the print is small, that's my pitch for you to download the book and these resources. You'll see a whole sheet dedicated to venous procedures. And there's only one code there for an IVC filter placement. So that points you to the right code. If you want to use this as a training exercise, you could work through this process when you do some cases, and then sit down with your coders a week or two later after they reviewed your report and see how you did. Good coders frequently use these types of cheat sheets, and if you want to participate in your practice's interventional radiology coding oversight, I would suggest that you should too. Another common service performed in most of our practices, again, another one that's not too high-end, is venous access. In your practice, just like ours, you perform all sorts of venous access. From a coding perspective, you see the considerations here that influence which codes you should report. If you put in a chest port in an adult, you'll use CPT codes 36561, 77001, and 76937 in most cases. You see the descriptors listed here. There's a different code for procedures in younger patients. Remember, this one says 5 years or older, and a different one for tunnel catheters without a port. This one says port, and for catheters that aren't tunneled at all. And different ones yet for whether you access a central vein or a peripheral one, such as in the case of a PICC line. So that 36561 describes the port itself. That's the surgical code. 77001 describes the fluoroscopic guidance, and 76937 describes the ultrasound guidance. In most of these cases, you're going to use all three of those. Now, how will you know to look for all these 3 codes? Again, you could page aimlessly through the CPT book, or you could use your SIR resources. If you go to the Venus Access sheet, you'll see a code for a chest port in an adult that will distinguish it from, say, a PICC line in a child. And you'll also see a reference to choose fluoroscopy and ultrasound guidance if performed, and so you'll pick those 3 codes. These forms are updated each year, and so if you familiarize yourself with them when they come out, you'll have a good handle on what you need to report differently and document differently as codes get changed from time to time. I'll wrap up with another not too complex family of services, that is imaging-guided abscess drainage. I'm intentionally picking straightforward cases to get you comfortable with the concepts of interventional radiology coding, and specifically how to use your SIR member resources. If you get comfortable with these cases, I'll encourage you then to attend the coding workshop sessions when you attend the next SIR meeting, where you'll learn a lot more about applying these principles to higher-end, more complicated services. But back to abscess drainage. You may have heard what folks say are the 3 most important things in real estate: location, location, location. And that's exactly how you'll CPT code imaging-guided abscess drainage procedures. Based upon what? Location. The code family for imaging-guided abscess drainage was revised a few years ago and greatly simplified. For almost everything you'll do in this domain as an interventional radiologist, you only need to know these 4 codes. The first is for a soft tissue abscess drainage. You can identify that one at the top by its placement in the 10,000 series integument and soft tissue surgery section of CPT. It's used for imaging-guided drainage of any soft tissue collection, such as in an extremity or an abdominal wall or in the neck, and applies to not only abscesses but also hematomas, seromas, or any other fluid collection. The next 3 are in the gastrointestinal surgical section of CPT, the 40,000 series of codes. These are used in the following scenarios. 49405 is used to report imaging-guided drainage of visceral organ abscesses or other fluid collections, such as a liver abscess. 49406 is used to describe percutaneous drainage of peritoneal or retroperitoneal abscesses or other fluid collections, such as a diverticular or periappendiceal abscess. And 49407 is used to describe drainage of a peritoneal or retroperitoneal collection that requires a transvaginal or transrectal approach. Here again, the coding charge sheets from the SIR are your friend. This is the page for all sorts of drainage procedures, including biliary and nephrostomy services. You'll see the 4 codes for imaging-guided abscess drainage all listed at the top right. These include whatever imaging guidance you use, ultrasound, CT, and/or fluoro. So these are all bundled one-size-fits-all codes. Your coder just needs to pick the one that applies for your individual case, and you'll then need to document clearly what you did so he or she can confidently apply the right code. As we wrap up in this module, please permit me to make a few final points. First, since your coders will need to apply codes based upon your report, documentation, just as in diagnostic radiology, is critical. But there's more you'll need to document than if you were just practicing as a diagnostic radiologist. Why? Because you're typically reporting more codes when you're practicing as an interventional radiologist, and each has its own specific documentation requirements. The next module will focus entirely on documentation in IR. And finally, you've seen an example of one of the many payment cuts that has impacted interventional radiology, that is, IVC filters. And you may be asking, why nobody from the interventional radiology community is looking out after you? The reality is that they are. And things probably would be much worse if they weren't. Many modules ago, we talked about the process by which CPT codes are initiated and approved. And I talked about the CPT Advisory Committee. The SIR has a member on that committee, currently Dr. Tim Swan from Wisconsin, who is highly engaged in the process and lets nothing in the interventional radiology space happen without his input. Every specialty society from any specialty has an advisor. Some of them aren't too active. Some are pretty active. SIR's is exceptionally active. You also know that the advisors, though, aren't the ones who make the codes. They just advise the editorial panel. And so it is that group of 17 individuals appointed by the American Medical Association's Board of Trustees that is the ultimate arbiter of what goes into the CPT code set. And interventional radiology is capably represented on that body of 17 physicians by not just one, but 2 interventional radiologists. For several years when I served on the CPT editorial panel, a second interventional radiologist, that is Dr. Kathy Kroll, a former SIR president, served as well. So interventional radiology had 2 of those 17 voices. And now that I'm term limited and have gone off the panel, it turns out that another interventional radiologist, Dr. Dan Pikus, who happens to be a former JVIR editor-in-chief, is now on the editorial panel with Dr. Kroll. And so again, interventional radiology retains 2 of those 17 voices. And those remain important voices. During my time on the editorial panel, I served on the 5-member executive committee of CPT. And now that I'm off, Dr. Kroll serves on that small and influential body. Interventional radiology, rest assured, is well represented at CPT. In summary, interventional radiology CPT coding is complicated, related to both the unique component manner in which interventional radiology services have been historically coded, as well as the rapid evolution of the specialty. Considerable resources are available for interventional radiologists who seek to improve their revenue cycle activities. Coding and billing for interventional radiology services, like pretty much everything else in healthcare, is best carried out in a team-based manner. To ensure appropriate credit for this module, please make sure that you complete the accompanying online quiz from the RSNA's e-learning platform. If you're in a vascular and interventional radiology training program, you'll also need to complete the second module in this short Advanced Vascular and Interventional Radiology course, in addition to the 5 core levels of REPLETE, to fulfill your milestones requirements. More information on the REPLETE initiative and additional resources are available on the RSNA's website, and specifically on the landing page for this module. I'm Rich Duzak from Emory University, and I look forward to helping you continue along your economics and health policy milestones journey. Again, thank you for participating in REPLETE.